Hello, everyone, and thank you for joining us for Arthritis Talks, Arthritis Prevention. I'm Dr. Sean Bevan, Chief Science Officer at Arthritis Society Canada. First off, I want to acknowledge that while we have come together for this event from many different places, I would like to acknowledge the land on which I am located on and which the Toronto office stands. This is the traditional territories of the Mississauga of the Credit First Nation, Anishinaabe, Huron-Wendat, and Haudenosaunee Indigenous peoples. Today, this meeting place is home to many First Nations, Inuit, and Métis peoples, and I am so grateful to have the opportunity to work and live on this land. Now, every day we get so many questions from people wondering if there are ways that arthritis can actually be prevented. Fortunately, more and more research is being done in this area, and tonight's expert, rheumatologist and clinician scientist, Dr. Choi, is at the forefront of this research. Tonight, Dr. Choi will share her insights to help us all have a better understanding of arthritis prevention. Now, before we get started, a few logistics. First, this webinar is best viewed on a laptop or desktop computer. If you have technical difficulties, please email arthritistalks@arthritis.ca for assistance. If you have a question for our presenter, you can submit it through the Q&A button at the bottom middle of the screen, and we'll try to get to as many questions as possible during the hour that we have together. You can click on the chat icon also in the bottom middle of the screen to access the chat and connect with other participants, as well as our chat moderator. Now, if you find that distracting, you can close out of that window completely. Just click the X icon to close out of the chat. And to enable closed captioning, please click on the Show Captioning icon in your controls toolbar at the bottom of the screen. So many questions we received in advance followed similar themes, so we'll get to those first before going into a live Q&A at the end of the session. But before we get started, I want to thank our event partners, including Pfizer and others, for their financial support of our Arthritis Talks series. Now, with that, let's get started. A very warm welcome to today's expert, Dr. Choi, who is joining us from Calgary. So welcome, Dr. Choi. Could you get started with elaborating on why is it so important to diagnose arthritis and other autoimmune diseases early?
Thanks, Sean, and thank you everyone for tuning in. So absolutely, I would say that it's interesting, despite all that we have done in the past, past century, to look for new treatments, look for new ways to diagnose patients, I would still say that autoimmune rheumatic diseases, including those that cause arthritis, are still associated with higher morbidity, disability, and mortality. So take, for instance, lupus. Lupus is a relatively uncommon disease, relative to things like cancer and heart disease. But I think it's kind of shocking if you look at the statistics that lupus is a leading cause of death among young females. So here in this figure that I've borrowed from this really well-cited paper that shows you that among young females, lupus as a cause of death is ranked number 7. Here, number 1 is cancer and number 2 is heart disease. And you can see in purple, lupus is number 7. And if you look at among Black females and among Hispanic females, lupus is ranked even higher. It's ranked number 5 as a leading cause of death. And so I would say that we've come a long way over the last century, but there's still a lot of work to be done. And so why are we seeing these high mortality rates? I think there are many reasons for that, but I think 2 really important reasons that all scientists agree is that 1, we don't really know what causes arthritis from autoimmune diseases and our autoimmune diseases in general. So it would be nice to know exactly what pathway or molecule or what part of the immune system is causing the issue, because then we can try to find therapies that target that pathway. But if we don't even know what that pathway is, it's very hard for us to find these therapeutic options. And same issue, we can't find preventative therapies if we don't know what's happening at the level of the immune system. And the number 2, which is really the focus of today's talk, is being diagnosed too late. So actually, most of the patients that I see they tell me that they've had symptoms for years, many of them. So by the time they come and see me, I would say that they are already at a very late stage in their disease course. It's almost akin to being diagnosed at stage 4 cancer, where the disease has already spread to multiple organs. And despite the treatments that we give them, a lot of the what we call organ damage is no longer reversible, even with the drugs that we use to treat them. So I would say that the majority of our patients were being diagnosed and treated way too late in the disease course. So here are just some numbers that were given to me by experts from all over Canada who see lupus patients, who see scleroderma patients, who's doctors who see patients with rheumatoid arthritis. You can see that a significant proportion of these patients already have pretty advanced disease. 30% of patients with lupus already have kidney problems when they come and see us at their first visit. Half of the patients with scleroderma already have evidence of lung disease within 3 months of being diagnosed. And 30% of patients with rheumatoid arthritis within a year of diagnosis already have joint damage. Again, things that we cannot reverse with our medications. There's been a lot of research to say, how does this actually affect patients in terms of their quality of life? So most patients would say overall being diagnosed late has negatively impacted their health. It has led to their condition worsening, job loss, disability, increased healthcare costs to the system. And back to the patient level, these patients have undergone a lot of unnecessary testing. Some of these tests are invasive and they have to undergo a surgery to get it done, or go to a radiologist to get ultrasound guided biopsies. So there's a lot of uncertainty and anxiety during that time, and many patients have to go to a doctor 3 to 5 times before formally getting diagnosed with an autoimmune condition. And all of these things contribute to one another in a vicious cycle. So, this has become a really important area of research for scientists. How do we get our patients diagnosed much earlier before they come and see us with all of these, what we call organ damage, that we can do very little to help them with, and have to give them, toxic therapies to suppress their immune system, prevent further damage.
Thank you so much, Dr. Choi. You raised so many important points just in that intro. Given all of that, could you explain what some of the signs and symptoms people should really be looking out for?
Yeah, so this is a challenging question to answer because even within the same disease, our patients can look so different. And sometimes patients may not have symptoms at all in the early stages. And that's part of the issue as to why patients are being diagnosed so late. So I'll give you an example. Here's lupus again. I can't help it because I was trained in seeing lupus patients. But the same principle applies to other diseases. So lupus is a chronic systemic autoimmune rheumatic disease that can virtually affect virtually any organ. So in this picture here, I have skin and joints. So I have some patients who just have the rash, they just have the arthritis, and they would have lupus. I have some patients who do not have skin or joints. They only have lupus in their kidneys, and they're still called lupus. I have some patients who don't have any of those, but they have lupus in the brain. And so you can see it can be very hard for a rheumatologist to make a diagnosis if all the patients look so different, if you're just relying on patient symptoms. And I just wanted to reiterate that a lot of our patients who get autoimmune diseases are young females during their reproductive years. Many of my patients are just starting to have families and starting their career. And so we have to be careful when we're selecting the medications that we give them, because some of them can affect their fertility, and some of them can also be toxic to the fetus when the woman is pregnant. And then the other thing that I wanted to reiterate, that it is a disease that's more common in severe and non-white race ethnicities. And so when I see a patient of that background, these patients often have more severe arthritis, or they're more likely to have kidney involvement or brain involvement that require much more heavy-duty medications to control. So I would say in general, signs and symptoms are helpful, but they are, because they're so non-specific, and there are many other things that can cause, symptoms like fatigue, any things that can also cause rashes that look very similar. I would say the signs and symptoms are not the most helpful, especially if we're trying to diagnose patients earlier, when those signs at the earlier stage are non-specific and sometimes invisible.
Okay, so given the challenges related to diagnosing based on signs and symptoms, could you just elaborate on how is arthritis and other autoimmune conditions, how are they diagnosed?
Right, I can see how that would be the next follow-up question. So right now, we really rely on the patients, seeing their family doctor when they have symptoms that they're concerned with. And like I said, it's by the time they already have symptoms, they've probably already had the autoimmune disease for a few years, but has not been an issue up until they started to experience pain, fatigue, the rashes, like I showed you on the other slide. So typically then the next step is that the patient goes for some basic workup. Usually that includes blood tests and imaging, like x-rays, for example. If the patient has enough symptoms and they have enough positive tests, then they are ideally then referred to a rheumatologist who has experience in making that diagnosis and then initiating the appropriate treatment. But like I said in the previous question, relying on the patient's symptom is often challenging. There could be a delay in the symptom onset, a delay getting the screening blood test because the symptoms are so nonspecific that sometimes the family physician has difficulties, even deciding which test to order. And then some of the screening tests are not very specific either. So one of the most common tests that many people may have heard of is the anti-nuclear antibody test, or the ANA test. And that's often ordered as the first screening test for autoimmune disease. That's great in that it's very sensitive, but 20% of the general population also have a positive ANA test. So then how do you know that your ANA test actually is relevant, and therefore you should go and see a rheumatologist? So we need better tests. We need better ways to screen our population for autoimmune diseases. And again, because our tests are not perfect right now, there is that delay between step 2 and step 3. So what kind of blood tests? I mentioned the anti-nuclear antibody test, but there are also more specific biomarkers in the blood called autoantibodies that are produced by the immune system when a patient has an autoimmune disease. So in the picture below, you'll see that there's like a timeline. It starts off with genetic risk. So what I usually explain to patients is that the reason why they develop this disease, probably there is a genetic component to it. So they start off with a genetic predisposition. Potentially somebody in the family had an autoimmune disease, and they have a gene that puts them at risk of developing autoimmune disease, but that gene alone is not enough to actually push them towards the other end, which is when they actually develop lupus. And I'll explain to you later in another slide I have prepared that explains why you get pushed from the yellow bar all the way to the dark blue bar. But in between, you can see that there's this kind of gray zone where the patients have inflammation in their blood and they have some non-specific symptoms that then build up to the eventual clinical disease part. But right now, we're seeing patients at the dark blue end. And what scientists are now trying to do is really shift that mindset to seeing patients much earlier, kind of in the light blue zone, where patients haven't actually developed symptoms yet. But if you check their blood, they actually already have signs of lupus or scleroderma, RA. And there's lots of studies that have shown that even almost 10 years a person is diagnosed, these changes have already happened and are detectable in the blood. So this is a study that I was part of that showed us that the antibodies, the blood markers, have been reported in these studies for over 9 years before a patient has started, prior to their disease onset. That's like almost a decade. this one is kind of reiterating the same message, but I wanted to show you this specific study because a lot of scientists cite this study in their research. It's a very, very important, what we call a seminal paper in our area, and it was published in the New England Journal of Medicine. So what this study was, they had blood from people who were in the American military, and they found all the people who developed lupus. And when you're in the American military, they biobank your blood every year. So they were able to go back in time and test their blood before they were diagnosed with lupus. And you can see on the vertical axis, you can see this is the number of patients who had positive autoantibody tests, so the markers that are specific for lupus. And you see that the number of patients with a positive test continue to rise over time until they're diagnosed. But the really cool part of the study is that you can see that even 5 years before diagnosis of the first symptom of lupus, many patients are already positive. So that's just saying that there is that kind of gray zone area that patients are already at risk of developing autoimmune disease and have not yet been picked up. So this is really an opportunity potentially for us to do something to stop that progression from happening. And not just antibodies, but inflammation in the blood can be detected. So this is another really important study that was published in the Annals of Rheumatic Diseases, a top rheumatology journal, that showed you that years before a patient is diagnosed with SLE or lupus, there's already rising levels of inflammation in the blood.
So really interesting, Dr. Choi, to see how early some of those markers are coming up. Could you just comment a little bit on who is at risk for getting an autoimmune disease or most at risk?
Yeah, so this goes back to an earlier slide. You can see that timeline. So we think that there is a large proportion of the risk is due to genetics. However, genetics alone does not explain it. And actually, the majority of my patients don't have a family history, or if they have it, their children don't end up getting an autoimmune disease. So why is it that then they then progress to getting the autoimmune disease and other people in their family do not? So I think what's important here to show is, so you start off with a genetic risk, and then there needs to be something in the environment that then triggers the immune system in that genetically predisposed individual to cause this cascade of immune dysregulation. So that leads to the antibodies being formed, the inflammation in the blood, and eventually all of these things lead to damage in the organs. And when you have the damage to the organs, that's when you develop symptoms. So we hypothesize that this is probably the way that people develop autoimmune diseases, but we're not entirely sure. So then, what are the environmental factors? Again, we're not entirely sure. We think that there's probably multiple environmental factors that can contribute to the development of autoimmune diseases. And these ones that I have listed here are what we call association studies, which means that in the studies, we haven't exposed these patients on purpose to smoking and then seeing whether or not they've developed lupus or an autoimmune disease. But we know, going back in time, looking at the study, looking at these patients, calculating how much smoking exposure they had, we can see whether or not there's been a correlation to see whether or not these specific individuals are at higher risk of developing lupus. So these are hypothesized to contribute to the risk. So we think that cigarette smoking is an important factor for developing autoimmune disease. In some autoimmune diseases, actually moderate alcohol consumption is protective of developing autoimmune disease. We think that some hormonal factors, obesity, exposures to certain infections and viruses are triggers for autoimmune disease. UV lights, medication, silica, pollution, and vitamin D deficiency have also been listed as potential environmental factors. So again, you have the genetic risk, but then once you get exposed to these environmental factors, we think that it then leads to immune dysregulation in that subset of individuals already at genetic risk of developing lupus, rheumatoid, scleroderma. So this is a study where I was involved when I was training in Boston, where we showed that, again, this is what we call an association study, where we looked at people who developed lupus and then looked at their lifestyle in the past. So we looked at smoking, alcohol consumption, exercise, their weight, and their diet. And what we did was we said, well, if all of the participants in this study had a very healthy lifestyle, had adhered to all 5 things, so did not smoke, had a healthy weight, exercise 30 minutes a day, what is their risk of developing lupus? So they did all 5 things, and we found that nearly half of the risks may be reduced if they had adhered to these healthy lifestyle behavior, which was a big surprise to many rheumatologists and lupus experts, because again, we were thinking genetics had a lot to do with it. But this study showed that nearly half of the risk could be reduced if you just did these 5 things. And then chronic sleep deprivation or chronic low sleep duration of less than 5 hours a night was also associated with increased lupus risk.
Okay, so thank you, Dr. Choi. Now, are there things that people can do to prevent or lower their risk of developing arthritis and other autoimmune conditions?
Right, so you could probably think about a few things already, because in the last slide, I showed you some what we call modifiable lifestyle factors, so things that people can actually change about their lifestyle to try to reduce their risk. But there are things that we cannot change about ourselves, like our genetics, our age, our sex. So let me talk about some of the things that right now we're recommending to patients. So like I said, right now we have patients who are being diagnosed at the clinical disease, the dark blue phase, where right now we're recommending this medication and that medication. But what if we could see these patients much earlier and change that to exercise more, eating a healthy diet, quit smoking, because we're concerned that you're at very high risk of going into clinical disease. These are the things that you need to work on. There's not necessarily any medications that you can take, but there's been these studies that have shown that having a healthy lifestyle can reduce your risk by almost 50%. So what about drugs? What about medications? So in lupus, we have found that other than counseling patients about lifestyle modifications, there's been a really important trial that I'll show you in the next slide, where they showed that taking vitamin D plus or minus omega-3 fatty acid also reduce your chances of getting lupus. There's an ongoing study right now in lupus looking at hydroxychloroquine, taking it earlier. So these patients not with lupus yet, but have some symptoms, maybe have some positive blood markers, and seeing whether or not hydroxychloroquine would reduce their risk of developing full-blown disease. And similarly, in rheumatoid arthritis, there's been some studies looking at various medications, see if it could stop the rheumatoid arthritis or early rheumatoid arthritis from progressing into established rheumatoid arthritis. So this is the study that I was mentioning, and this is why I'm very comfortable asking my patients to take vitamin D plus or minus fish oil. So this is a very large study in the US with over 25,000 participants. And they asked these participants to take vitamin D, 2,000 international units a day, and or fish oil, and or placebo, and then followed them for approximately 5 years. And what they had found was that vitamin D, whether or not you were on fish oil, reduced your risk of getting incident autoimmune diseases by 22%. And if you combine that with fish oil, it further reduced your risk for a total of 30%. Fish oil was by itself was not what we call statistically significant, but there was a trend. So it reduced your risk by 15%, but it wasn't what we call statistically significant. But I still recommend vitamin D and fish oil because I think there's very little risk to taking fish oil. And certainly vitamin D is great. I think we're all vitamin D deficient here in Canada. So I think taking vitamin D and omega-3 fatty acid is something that I can easily recommend to my patients, especially, I see some of these patients who are at high risk. They come in with non-specific symptoms, but I don't want to commit them to a medication yet. I say, do these healthy lifestyle modifications, but in addition to that, you can also be on vitamin D and fish oil and see if it makes a difference, because this trial did show that it was beneficial. So I think there's some scientific evidence to back me up now, which is really, I think patients really like that.
So before we get into the Q&A from today, I always like to ask people, what excites you about the future of arthritis and those diagnosed with arthritis today?
So I think it's a very exciting time to be a rheumatologist, because I do believe that we are able to do so much more for our patients today and tomorrow. There's a lot of exciting research, and yes, there are many, many clinical trials that are active right now, recruiting patients for these new drugs, new therapies. There's even now a therapy called CAR T trial that basically is potentially a cure for some of our autoimmune diseases. So it's a very exciting time in the world of therapeutics for autoimmune diseases. Artificial intelligence is also being widely used to study our diseases. I would say that artificial intelligence is very important for us scientists to understand what's happening at the cellular and molecular level, because the immune system is so complex. And we now have so much information on our patients. Traditionally, when we were doing studies, we were collecting basic information like age, sex, race, what were their presenting symptoms, what did their basic blood work look like. But now we're so good at collecting information on our patients that goes down to the molecular level, that the databases that we have on our patients span thousands of variables. And then we're continue to follow these patients every year. So then, it becomes a whole a database of many, many pages on just one patient. So to be able to understand all of that data, machine learning has become a very important tool to look for these patterns in the database that we can't see using traditional statistics. So very, very exciting time for AI to be available and to be integrated into the research that we're doing. And this is an example of how that's being done right now in rheumatology. So this is a diagram that shows you, we start off with the patient, and the patient's blood, other tissues and fluids are being collected and biobanked. And then when the scientists think of a research question, they process the sample and they send it up for DNA, proteins, different molecules like lipids. And then all of that information goes into an artificial intelligence or machine learning algorithm that then tells the scientists, these are the most important biomarkers that can help you make a diagnosis. These are the most important mechanisms of disease that we should be targeting with our new drugs. And we can do that very, very quickly because machine learning is very powerful. So and that forms the crux of what I'm doing in my lab. It's called the Artificial Intelligence Autoimmune Diagnostic. So we combine novel biomarkers that we're looking in the blood, but we also collect other specimens, including saliva and urine, to try to look for those early biomarkers in the blood to help our patients get a diagnosis more efficiently. And then we use artificial intelligence to kind of look at all the biomarkers that we've been testing to find out which ones are the most important ones. And then we also have an excellent knowledge translation team that also involve patients to help us understand that data and spread awareness. So I'm really, really lucky to be part of this team. Again, kind of illustrating how exciting it is now for a rheumatologist to be involved in research, and for a rheumatologist to then take that information and help our patients. And then, yes, these are pictures from my lab, kind of reiterating the same points about the AI, the biomarker, and really doing all of this to help patient care.
Okay, that's amazing, Dr. Choi. Thank you so much for sharing your expertise with us today. Not surprisingly, we have received many questions. So if it's okay with you, I think we'll just get right into it.
Yeah.
Okay, this first question here has come up a lot actually, but it's kind of foundational because we certainly have an audience, some of whom have osteoarthritis, some of whom have inflammatory forms of arthritis. You are obviously a rheumatologist. I just wonder if you could just give a bit of grounding first for our viewers about, what are the different types of arthritis in broad strokes, and how do some of the types that you talked about today, lupus, rheumatoid arthritis, et cetera, how do they all sort of fit together for people?
Yeah, absolutely. So in our minds, we think of arthritis as one of the ways you can categorize it is inflammatory and non-inflammatory arthritis. And then within those, there are also different categories. But the general category of inflammation, non-inflammation helps us kind of right away differentiate, you can almost say osteoarthritis, which is non-inflammatory, meaning that if you check their sample in the joints and you took it out for analysis, there's less inflammation in there compared to somebody who has, say, inflammatory arthritis from rheumatoid. And then the symptoms are slightly different too. Somebody who has non-inflammatory arthritis may not have as much stiffness and swelling as somebody who has inflammatory arthritis. And then under the umbrella of inflammatory arthritis, you can get like autoimmune arthritis. So that's where you have the lupus, you can have the scleroderma, you can have the rheumatoid arthritis. And then you can have even more extreme inflammation where you see with infection related arthritis or crystal arthritis with gout and pseudo gout. And so in my mind, that's how I kind of separate it. They all affect the joints, but often, as I explained to you, it's not just the joints. Within an autoimmune inflammatory arthritis, you can see that there are many other symptoms, other organs that can be involved in addition to arthritis.
Okay. And so can people have both osteoarthritis and an inflammatory form of arthritis together?
Absolutely. Absolutely. We see that actually quite often, that there's a combination of both. And so that's really important, because if a patient has, for example, rheumatoid arthritis that is well controlled with their current medications, but they still have pain and their arthritis looks like their progression, we also have to make sure it's not because it's their osteoarthritis that's advancing. And so often we have patients who have rheumatoid arthritis who need joint replacements for the osteoarthritis. And once they get their joint replacement, they're great. So yes, we have to keep both in mind because they can happen together.
And so what about those early signs and symptoms or early markers that you look for? Again, when you're comparing osteoarthritis or an inflammatory form of arthritis, can you distinguish between those for a patient?
For early signs?
Yeah, or signs and symptoms that you would see. What would be different from somebody who has osteoarthritis versus someone with an inflammatory form?
Yeah, great question. All these questions are great, by the way.
Right.
So I would say osteoarthritis tends to be limited to the joints relative to the types of arthritis you would get with autoimmune. Because the key with the autoimmune arthritis is that often they're systemic, meaning that the inflammation that is affecting the joints is also floating in their body and affecting other organs. So often these patients feel really unwell when their autoimmune arthritis is flaring. So they may also have the rash, may feel more fatigued. They may have chest pain if their heart's involved. So I would say more systemic versus localized symptoms, and localized more to the joints if it's osteo.
Okay, really, really helpful. And I think just helps to kind of level set for people who are wondering. Okay, so kind of similarly along the lines of how does the information that you presented today relate to different types of arthritis? You talked about different risk factors. You talked about smoking, genetics, other things. Again, questions about, do these apply just to one form of arthritis or inflammatory arthritis or OA as well? Could you comment on that, please?
Yeah, I would say, I know I focused a lot on lupus, but again, the same principles apply to definitely the autoimmune rheumatic diseases. So rheumatoid arthritis, you can draw a very, very similar diagram to the one I showed you, the genetics, the asymptomatic autoimmune inflammation, and then disease. And you can do that for scleroderma, you can do that for rheumatoid. Oh, I said rheumatoid already. So yes. And then osteo also has, genetic predisposition. And then, but the risk factors are a little bit different because the mechanism of osteo is slightly different from what you would get with autoimmune, because autoimmune is more of the immune system being dysregulated. That's where you see the antibodies, which we don't see in osteo. But the genetic risk is often something that I do tell my patients about, even with the osteo. And one of the things I would say, if I see very bad osteo in the hands, one of the questions I ask my patients is, does your mom also have a lot of osteo in their hands? And almost every time my patients say, yes, my mom's hands look exactly like mine. Like lots and lots of nodules and large joints here, which we call the DIPs and the PAPs, almost identical. So there's some almost like maternal transference with the genetics for osteo. And it's, my patients always seem very surprised when I mention, they're like, yes, I do see that. So genetics is still an important part in osteo for sure.
Okay, super helpful. Questions here about what about other autoimmune conditions? Is it common for somebody that you see with arthritis to also have, say, asthma or different, types of autoimmune conditions together? Is there any correlation?
Yeah, definitely. For example, thyroid disease is very common in our patients. And so we think once your immune system is primed, you're higher risk of developing other autoimmune diseases because it's so sensitive. And again, there's probably a lot of mechanisms that are overlapping between the diseases. So for sure, there is increased risk for other autoimmune conditions.
Okay. A question just came in actually. When are people with inflammatory arthritis, when are they typically diagnosed? Like, could it arise in older adults, for example?
Yeah, so it depends on which inflammatory arthritis you're talking about. We see so some diseases affects young women, and then so that's very common for lupus, rheumatoid arthritis. We see it in scleroderma, and then we have some patients who get diagnosed much later in their disease course too. So it really depends which disease you're talking about, because there are some autoimmune diseases where the male to female ratio is actually quite equal as well. So I would say, and I think that speaks to how heterogeneous our diseases are. Yeah.
Mm-hmm. Okay. You also talked about some prevention strategies like diet and exercise. Again, questions here about, is that applicable to all forms of arthritis or only some, or do we know more in certain conditions?
Yeah, so I would say we probably have more information in some diseases like lupus and rheumatoid arthritis compared to some of the rarer ones. But overall, my general advice to patients, regardless of which autoimmune disease that they have, it's good to practice, a healthy lifestyle, because I don't think it's harmful to do it. So stop quitting smoking in general. It makes sense in my mind. Smoking is very inflammatory. You're inhaling all those particles that are, aggravating your immune system. And so there's a lot of research to explain the connection between smoking and inflammation and autoimmune disease. So kind of across the board, and just, I think, health in general, I would say, stopping smoking, exercising, maintaining a healthy weight and diet are things that I just generally counsel patients about, regardless of which subtype they have.
Mm-hmm.
Mhm.
You also mentioned fish oil and vitamin D. Are there any other supplements that there is strong evidence for around arthritis risk reduction, prevention?
So far, I would say there are lots of smaller studies that may show that a certain supplement is helpful or not, but I would say this vitamin D and fish oil one has gained the most traction. And I would say most rheumatologists feel comfortable saying that these two are the ones that you can try. And less so, I think evidence for the other ones are not as strong. So you may Google something or ask me, oh, look at this study, it showed this. I would say there are probably many studies like that, and there are limitations in those studies. So just be careful about everything that you read on the internet. But when a trial is done like this, with over 25,000 participants and followed carefully over 5 years, with experts who are, experts in clinical trial and doing epidemiology studies like this, I think that kind of evidence is pretty robust.
Okay. And just a clarifying question, is vitamin D the same thing as vitamin D3?
Yeah, I would say vitamin D, vitamin D3, there are many different forms. So yes, you can take vitamin D3 and that should be fine. Yeah.
Okay. This is a good question. Does somebody need to see a rheumatologist if they have osteoarthritis?
I think that varies from where you are. There are rheumatologists in some centers that see osteoarthritis and are experts in osteoarthritis. So I know, like in London, Ontario, Tom Appleton is an expert in osteoarthritis, and he's fantastic. There are lots of researchers at University of Toronto who also do a lot of research in osteoarthritis. So certainly it is one of our diseases. And then if you look across other provinces where we have a very long waiting list, and we're trying to see as many patients with these very acute, severe patients, often in hospital, we see them much sooner. So we do see osteo, but we have to prioritize some of these other conditions that really need a rheumatologist involved in terms of starting these heavy-duty medications. So I think it differs from like where you are, but yes, we do have some experts who are dedicated to seeing osteoarthritis, and then we see it also by default because our patients also have osteo with their autoimmune condition. So, and we do know how to manage osteoarthritis.
Okay. I feel like Tom is going to get a lot of emails and phone calls pretty soon. Okay. He's a good friend. Okay. The question here is it possible to have no inflammatory markers come up in your blood work and still actually have an inflammatory form of arthritis?
Great question. So yes, definitely, because I don't think we've found all of the markers yet. So you may be one of the patients who we call seronegative, and it may be seronegative because we just haven't found it. We just haven't discovered what that biomarker is. We have something called seronegative rheumatoid arthritis, which is where you're negative for anti-CCP and rheumatoid factor. We call it seronegative just because you're negative for those two biomarker, but it doesn't mean that you truly have nothing in your blood to suggest that you have autoimmune disease. So that's where research is really exciting.
Yeah, we don't know yet.
Yeah.
Just back on the vitamin D question for a second. A question here about how early is it okay for somebody to start vitamin D, kind of in this context? Is there any timeline that you would suggest, or just in general, it's a good thing to do?
Yeah, I would say just in general, I think it's good to take vitamin D. I think there's very little harm if you're taking the recommended doses. If you're talking about prevention of autoimmune disease specifically, I think that's where we're still trying to figure out what is that gray zone, right? So right now we know patients can have autoimmune disease findings in the blood up to 10 years, but we don't know when did that actually start for that patient. So I think right now researchers are trying to develop studies, clinical trials that identify patients at that genetic risk zone, so very early, and then try to intervene during that time. So we don't even know when that starting point is. And I think a lot of research is going into that to find out when that gray zone is for you to start vitamin D if you're truly talking about for the prevention of autoimmune disease.
Okay. You gave a really nice summary about how arthritis is diagnosed. A question here about how common is it to have that diagnosed change over time? Does it happen?
Yes, it can. I think there are, so especially if you get kind of diagnosed in the early stage where you may have some non-specific symptoms, some positive blood tests, but they're not definitive. We have many patients in this gray zone we call it undifferentiated connective tissue disease. And then over time, the disease presents itself. And then you're like, oh, I thought you were going to be somebody with rheumatoid. But then a few years later, the markers change or finally show up, just like remember in that sketch chart that I showed you with the rising number of patients with positive antibody tests. So, sometimes those markers eventually pop up and you're like, oh, this was lupus all along, or this was scleroderma all along. And sometimes we're now seeing patients who have two diseases. So they may have started off with rheumatoid, and then later on, their symptoms are kind of changing into lupus. So now they have rupus. So they have rheumatoid arthritis and lupus together. So definitely, I think people's immune system can change, and that maybe they had both to start off with, but then the markers just don't show up until much later.
Okay. I feel like this is a big question, but just maybe share with us what you know. You talked a lot, or you mentioned how some of these diseases can be more severe in non-white populations. So fundamentally, the question is why? What do we know about that?
Yeah, so I think it goes back to genetics as part of the reason. And so I think that there are probably some races where they have a stronger, gene for that disease. And I also think that it's probably multifactorial. There are some populations that have less access to care. Some of these communities are more remote, so they don't have access to the testing that we have in tertiary centers. They don't have access to physicians and the medication. So by the time they do come and see us, they are those patients who are much, much more advanced. So I think there's a social aspect to it, a cultural aspect to it, in addition to probably the molecular genetic aspect. So yes, it is a very big question. And one of my research goals over the next few years is actually to improve diagnostic testing for some of these remote areas in Canada. How do we improve lupus testing, rheumatoid arthritis testing, if they are several hours away from a lab or a hospital? How can we improve that? How do we make these tests available to them? So that's a very important passion of mine right now. I'm hoping to update everybody in a few years to see if I'm able to figure something out with my team.
You stole my next question, which was, is there a lot of research in this area actually? So is it being looked at actively? So
yeah, there is. And this is not just I definitely don't want to take credit for this idea, because there are multiple rheumatologists within the past year with this exact same question. They weren't not talking to each other. They just came to me separately. And then I said, actually, we're already working on this with so-and-so. And I think that really speaks to the need for something like, for us to address this question.
Okay. Okay, question here about, are there any medications that can actually not necessarily reverse damage that has already happened, but really stop further bone damage in arthritis?
So specific to arthritis, you mean?
Yes. It could be different forms of arthritis. I'm not sure which one they're referring to specifically.
Yeah. I would say probably one of the most interesting therapies that's being tested right now, still very early in its stages, is the CAR T-cell therapy I was mentioning. And I won't go into too much detail about it, but it really resets your immune system to the point where patients are now off medications and have not had any of their symptoms return. It's very aggressive and also very expensive. And right now, we're still in the very early stages of testing this therapy to make sure it's safe, and to make sure, we're figuring out who should be receiving this type of very aggressive therapy. So very interesting time. So I think that I'm not sure if I'm addressing the question, but that is probably one of the more exciting and also potentially, yeah, stopping the autoimmune disease altogether is what we're hoping it will do for us.
Mm-hmm. Okay, a question here about do family physicians get trained to recognize and diagnose, I'll say inflammatory arthritis, but I guess both OA or osteoarthritis or inflammatory arthritis?
Yeah, it's definitely part of our training, our medical school training, and then family physicians are also fantastic, and they they are the gatekeepers, right? They're the first line of people to recognize those signs and symptoms. So absolutely, and we depend on them to send us the referrals and do the initial workup for our patients.
So can they order those diagnostic blood tests that you talked about earlier?
Yeah, so they have the caveat is, again, where you are in Canada, because there are restrictions placed on some tests that I guess you could order, but the patient would have to pay out of pocket in some instances where it's some basic rheumatology tests. But in general, yes, we should all have access to some of the initial workup. And then the more specialized autoantibody test is also available in Canada. And so I'm actually part of one of these labs. It's called Mitogen, and we offer more specific lupus or scleroderma or myositis tests that family physicians also have access to. And so once you kind of, have suspicion that this patient has an autoimmune disease, their ANA, like I mentioned, is positive, but you don't know which one it is. Sometimes it is helpful to order these more specialized tests. And we're very lucky in Canada to have access to that.
Mm-hmm. Okay. You talked about an increased prevalence of arthritis in women, for example, and a little bit, for example, about women who are in their childbearing ages. A question here about menopause. Is there any research that we understand around how menopause might either impact your risk of arthritis and probably inflammatory arthritis, or whether there's a connection there between menopause and how it could be treated?
Yeah, so I would say in general, I think hormones has been listed as a factor for developing autoimmune diseases. The reason being, we think that there are certain hormones that are pro-inflammatory, and it results in the production of inflammation and then induces autoimmunity. So fluctuation in estrogen, especially during those very specific times, menopause, giving birth, being pregnant. I think those are kind of very susceptible times where there are changes in the hormones that may lead to increased development of autoimmune disease.
Okay, and so I guess along those same lines, what about hormone replacement therapy? Are there any implications with that and inflammatory arthritis?
Yeah, I think so again, it's every disease is a bit different. Again, going back to what can hormones do to increase your risk of developing autoimmune disease, and also there may be some concern that it could even flare your disease if you're giving certain hormones, or even taking birth control pills. If you're at risk of developing clots, for example, if you have lupus, there are certain birth control methods that I would not recommend because of the increased estrogen content in some of these methods. So that's a very, I guess, tricky question to answer, because I think it's specific to the disease and specific to which hormone you're talking about. But I think that's something you should probably talk more with your rheumatologist to your specific case. Yeah.
Okay. I think I probably have time to squeeze in one more question, and probably one close to your heart. How can patients get involved in research?
Yeah, so very that is something that is very near dear to my heart. And I think I first I want to thank all of patients who have been involved in all the research projects that it's been a privilege to be a part of. And most of these patients were involved through the rheumatologists. So some of the rheumatologists are scientists themselves, and they have like a specific interest in a disease. And so we'll have a project already set up and the patients get recruited. There are also excellent societies like Arthritis Society that, they talk about their different researchers and projects that they're funding. So there are ways to get involved through going through these society websites, and they often have information on how to contact the researchers or and to get involved. And I think that's been excellent. And I've had patients reach out that way too. I have my own website as well with my research coordinator information. And then specific to trials. So patients who want to get on these clinical trials, say, for example, they've tried everything and they want to see what else is available out there. Clinicaltrials.gov has an excellent website that lists all the currently active trials that patients can be involved in and ways to contact the people who are running the trials to be screened to see if they're eligible. So there are lots of ways to get involved. Talk to rheumatologists, and visit these websites from these societies like Arthritis Society. Arthritis Research Canada is another excellent resource that talk about the researchers and what they're doing. And we are always happy to have patients involved in what we do, and we're really grateful for their time and donating their blood samples. We know that it's very meaningful, and without the patients, we would not be able to do what we do.
Okay, Dr. Choi, thank you so much. We got through so many questions. Sorry about the rapid fire there, but thank you so much for sharing your knowledge with us today. We would like to take a few minutes just to get the audience's feedback on today's presentation. So for those of you who are joining live on Zoom, you'll see a poll question come up on your screen with some answer options. So just click on the response that really does reflect your thoughts. I feel more knowledgeable and empowered after attending this webinar. We will also be sending you an evaluation form when we email the recording and the slides. So if you weren't able to access that poll question, don't worry, you can give us feedback at that time. And we really do use that survey feedback to shape future Arthritis Talks webinars. So thank you so much in advance for all of your input. We do have an exciting lineup of events coming up this spring, including a special Arthritis Connections on March 20th, and our next Arthritis Talks webinar on April 9th, focused on tips and tricks to manage your joints. More information on these sessions will be shared in an email with you tomorrow. And finally, donations do power everything that we do. They enable us to host Arthritis Talks and support people living with arthritis all across Canada through research, advocacy, and essential programming. You really can make a difference with us by donating today at arthritis.ca/donate. And of course, remember that any amount does help. Once again, we are grateful to Pfizer and our other partners for their financial support of this event. So with that, this concludes tonight's Arthritis Talks. On behalf of all of us, thank you for joining us today. Please stay well.